Okay, well, welcome back. I got to go this way. Okay, all right, can do. All right, well, welcome back to our third seminar in the Embedded Economist series. First two have been great, but I'm actually almost my favourite subject, which is around data today. So, and a lot of people don't like data, but I think understanding how to get the data, pitching your question, and then using the data is just such a key fundamental piece of this that I think it's going to be a critical seminar today for us. Rob Padbury's starting. I think, Jonathan, you're going to introduce things a little bit, and then we're into Rob again. We'll hear a bit more about Slido, so remember to look at the Slido page fairly carefully. You might want to put some questions up through Slido as we go along, but I'll hand over to you, Jonathan. Thanks so much.
Thanks. Yeah, so thanks, Andrew. Number three of five, so we're over halfway after today. Just to start with acknowledgements of country, so we acknowledge the Kaurna people, who are the traditional custodians of the Adelaide Plains, and we pay respects to their elders past, present and future. As Andrew said, Slido, please ask as many questions as you like through Slido, so just go to slido.com and the event code is #H7872. I have to quickly acknowledge the funders, Health Translation SA through MRFF and the NHMRC Partnership Centre for Health System Sustainability. And then onto the outline. So today Rob's going to talk about data and measurement, how data is collected and used for continuous improvement. And then I'm going to kind of talk about how I see the possible use of data to inform local economic evaluation, focusing on intervention design and implementation decisions. So without further ado, I'll pass over to Rob. I need to...
Well, thank you very much, Jonathan. I thought it was going to be the first time since 1991 that I was speaking to an audience that could be measured on the fingers of two hands. However, a 10th person walked in, so thank you very much. A slightly esoteric title, the unintended or measurement for quality and the unintended consequences of measurement. A few myths: manage only what you measure. If that was the case, we'd be in diabolical trouble. That everything must be measured, it most certainly cannot be. And that measurement should capture 100% of events, it can never do that. But let's see what we might be able to achieve. David Verbal was an expert in lean thinking who visited here, probably about 15 years ago now, or 16 years ago, something like that. He was a very, very entertaining and very informative individual, and he left with these messages, and I think they were extremely important. I'm not going to read all that out, but understanding what the problem is without assuming that you know, and then when you take action to fix it, assuming the action you take is doing what you wanted it to do. Obviously, there's a lot around measurement with that. Now, I think it's really important that we understand the data wisdom hierarchy. So we get a lot of data, but it's useless on its own. It needs to be converted into a variety along this hierarchy, firstly to information, but hopefully knowledge, ultimately intelligence, and finally wisdom. Machines or computers can go up to intelligence, but not wisdom. Wisdom is the final and human element. Listed here are characteristics of measurement according to the purpose. Across the top, performance, research or improvement, and the characteristic down on the left-hand side, the aim, testing strategy, sample size, etc. I'm not going to read through all these things, but just to indicate, and obviously these slides will be available later, that there are significant differences with respect to measurement and data according to purpose. Now, what we've been mainly involved in is improvement and research, But performance is obviously something that's of interest to institutions, organisations and systems. This is something we traditionally do in measurement, and particularly measurement for improvement, is try and find the tail, find the underperformers or the underperforming part of the organisation and chop that off, and that everything that sits inside the green is going well. Well, that's a fundamental fallacy, and the important thing is that if we only do that, we can shift the mean slightly to the left, but if we focus on the whole system and don't assume that everything that's happening in the green zone is appropriate or good, because it most certainly isn't, that we can make much more progress. So what are the different types of measure? Outcome: survival, disease recurrence, quality of life, morbidity, mortality. And I've put a rather provocative statement here at the bottom. These are not necessarily a good measure of, and the crucial word is real-time quality. Often these things can take years to accrue. And if you're waiting years, you can be in trouble. Also, some of the events occur very remote from the actions. For example, disease recurrence. Quality of life is something that we don't necessarily measure all that well. So let's look at an outcome. The divisional mortality of SAPOM as of this month is 1%. Is that good? Is it bad? If we were in an American organisation that had adopted the NESQIP system, we'd get information such as this, where mortality is plotted with confidence limits rather, and up here on the right-hand side, where the confidence limits don't pass unity, they're statistically inferior performance organisations with respect to mortality. So they've obviously got a problem that needs to be sorted out. The ones down here are performing at a superior level, not necessarily perfectly, but we don't get any information like this in the Australian healthcare system, so we have to try and find our own. In 2013, we did a project where we looked at the mortality and morbidity of patients undergoing emergency general surgery at Flinders, and we did an analysis of actual versus predicted according to a NESQIP calculator. Now, this is a database in the United States with 1.5 million events at the time that we did it, and it puts all sorts of variables in, and you come out with a prediction of mortality. So that just explains it, and you get a printout like this where at the top it says death, and then underneath the risk of serious complication, any complication, and a list of specific complications. And this is what we found. The predicted mortality in our cohort of patients was 6.6%, and the actual mortality was 1.4%. So this was reassuring to us. We had found some international standard at least. But what we don't know is whether other organisations in Australia perform at the same level, better level, worse level. But at least we managed to find some sort of standard. And this is the mortality of the division over the last 18 years. It only goes up to 17 there, but it's continued on under 1% up into 2020. So we have kept a flowchart of our mortality over a long period of time. And back in 2003, our mortality was between 3 and 5%, which is sort of a remarkable statistic. And over the passage of time, even with increasing complexity of patients and age and increasing complexity of procedures, we've managed to get that mortality down to under 1% consistently. Occasionally there have been a couple of spikes, and we've been able to then go back and audit those spikes to make sure there was nothing systematic happening, and in no occasion have we found that. But then along came this information. Mortality was reported to be dependent upon the day of the week the patient was admitted, and this made quite a splash. And we looked at our own, and that's what we found. So that the mortality of patients who died, the percentage of patients who died was much greater if you're admitted on a Saturday or Sunday. And you look at that and think, wow, how can that be? Does anyone have proffer a view as to why that might be?
Environmental factors, or
Sorry?
what people are up to on that on the weekend.
Yeah. Emergency versus elective. So, if we take out the elective patients, that's what happens. Very good. That it all flattens out. So this is the important thing about understanding what sits behind the data that you're presented. Because this made quite a splash, because what it was saying was hospitals were unsafe places on weekends because of the staffing arrangements and all the rest of it. But actually it was the effect of the decreased mortality in elective patients that made the difference. So most elective patients are admitted Monday to Friday, whereas emergency patients are admitted evenly across the 7 days. The death rate in elective patients is very small. Most deaths occur in emergency patients. So this was a big national news splash at the time. So what about survival rather than mortality? Survival after a complex procedure. So we produced this graph in about 2005, which was the survival after liver transplant at Flinders Medical Centre. 93% 1 year, 88% 3 year, 84% 5 year. We didn't really know whether that was industry standard. And so we compared it to some international benchmarks. The second line is actually the other Australian units, then the United States, and then Europe over similar time periods. So we could sit back here and rest on our laurels and say what a jolly good job we're doing. However, is it that straightforward? So I wasn't satisfied with that. So there is an international measure called a MELD score, which measures the risk of patients who are undergoing transplantation. And I compared the MELD score of patients at Flinders to publications in the United States. And I'm pleased to be able to report they were identical. So on a risk stratification, as far as we could do it, we were treating the same group of patients. So it wasn't just a patient selection, selecting the winners event. This was somewhat of a legitimised answer. Financial. Now this is just some measures that we can easily obtain. Following on from what I presented a couple of weeks ago, there is not a great correlation between quality, in other words, the quality as we define it, the 6 domains, and financial outcome at a unit level. And the important thing here is that this is DRG type coded information, and you need to understand what sits behind it. So the emergency elective mix will make a big difference to the financial outcome, even within the highest quality service. Now, 2 weeks ago, Sue asked me a question and said, where's the sweet spot? Where's the sweet spot between emergency and elective admissions? Well, the sweet spot is 100% elective, 0 emergency. That's actually the sweet spot. So in analysing any outcomes on a from financial information, you need to look and see what sits behind it. Now, it may be that there's information you can obtain about prostheses and consumables and see that they're too high. So that becomes relevant, but you've had to look behind to find it. There's lots of administrative things that can be, administrative type data that can be produced. It's usually time-based. So length of stay, relative stay index, standardised mortality ratio, time in ED, theatre utilisation, bed utilisation. But the validity of these things depend upon the definitions used, the type of the organisation, and so when I say the type of organisation, whether it's doing a lot of acute work versus elective work and so on. So once again, it is important to look behind. Here's the RSI traced over a period of 12 months or so within the division of surgery. In the 12-month period, it's about 12 years ago. So just where you're meant to be is around 1. But this relies on coded information. And so if you, once again, returning to my example 2 weeks ago of the laparoscopic cholecystectomy, the emergency versus elective, our RSI for laparoscopic cholecystectomy at Flinders Medical Centre would look terrible because it's using that coded information. So you just need it. So what I'm saying is that it's not that these shouldn't be measured, it's that you need to understand what sits behind it and evaluate it. In the interests of time, I won't go through that. So I was talking about some outcome measures. What about process? So process is measuring something, what part of a process that leads to an outcome. It might be how often was appropriate care given. It's measuring against some agreed standard. For example, risk stratification of people coming into hospital for DVT prophylaxis. It can happen in real time or recent time, which is good. It can focus on the whole system, not just the end. In other words, you can look at the reliability of things that are happening. The assessment can be made on small numbers. It lends itself to repetitive audit. It is a good measure of quality delivery of this particular process, but for it to be relevant, it has to be representative of all your processes that are ultimately producing the outcome. And I'll show you what happens when that doesn't occur. It is the best benchmarking, the best benchmarking of this is with your own system and increasing your reliability. It's very relevant at the front line and better when concentrating on improvement rather than judgment. Now, there's a thing that came up that was developed originally in finance, Goodhart's law, also known as Campbell's or Lucas. When a measure becomes a target, it ceases to be a good measure. And what this means is that the system is distorted by managing the measure rather than the measure being representative of the overall set of processes. And when this happens, we end up in trouble. You see, there are three ways to achieve targets. These are process targets. Change the system, which is a detailed operational challenge. We can distort the current system to meet the target. I wonder if anyone can think of where that might happen. Or we can, of course, manipulate the data. Now, what I'm about to show you is a real graph. It's elective surgery overdues in our health system, our own health system. Now, this is a graph from about 10 years ago, but the same thing was applying until relatively recently. The target was, on the 30th of June in any one year, there shall be 0 overdues. And indeed, there were 0 overdues on the 30th of June, pretty much. So this pinky colour was Central North, so that's now the centre and the north joined together, and then we are the blue line here. So as you can see, there was no sustained improvement happening here. There was no changing the system to keep a consistent flow of patients. This was very much about hitting the target on the 30th of June, and the 14th of July, it would be all back to business as usual. So it's important that we don't let that happen. And that's why I think a lot of the things we're focusing on now is sustained improvement, not at a time point and then another time point 12 months later. It's a matter of monitoring. So this is DVT prophylaxis within general surgery at Flinders. When we first started this, February 2006, we were getting it right about 60% of the time, which seems pretty low. So we did a lot of improvement work, and then we undertook repetitive auditing over every 12 months or so. We'd audit for another month. And this is up to May 2010, but we've managed to maintain this up to 2020. So we're now getting it right somewhere between 80 and 100% of the time, rather than 60% of the time. The traditional measure of effective DVT prophylaxis is pulmonary embolus, or being admitted back to hospital with a DVT. And you can see down here, this bottom line, that's an absolute flat line. And it tells you nothing. It's a remote outcome event of low frequency, and it tells you nothing about the reliability of your process. And so even though that's been the traditional measure, quality measure, it's totally useless. You need to actually measure what is happening in this example. So low frequency, remote outcome. You need to measure or find a process measure that's appropriate. This is just from the study, the Australian Quality and Healthcare Study. I'll just focus on this one figure here. Patients who had received appropriate chemical anticoagulant therapy, 40%. 40%. And that's a fairly consistent number internationally. Let's go back a bit. Colonoscopic surveillance of people at risk from developing colorectal cancer. We did a baseline audit of what we were doing in 1999. We just audited 100 patients. These were high-risk patients, and we figured out how often we were getting it right. We were getting it right, I'll go one that way. We were getting it right 39% of the time. So we undertook an improvement project where we did a lot of things. We put automated follow-up and did a whole lot of stuff, the detail of which I won't go into. What we found was we were actually doing this far too frequently and not adhering to NH and MRC guidelines. And on the other side of the ledger, 23% of patients were getting lost to follow-up. So the quality of what we were producing was appalling. But since 2000, we've maintained our rate of adherence to NH and MRC guidelines to very close to 100%. Same thing in surveillance in Barrett's esophagus. This is just surveillance for people at risk of developing esophageal cancer. We were getting it right 18% of the time, 18. And it's very confronting when you go and look at this sort of real-time quality to discover what's happening. And by making similar adjustments, we've been able to improve the quality of that. So the picture I'm trying to paint here is that there are multiple methods of obtaining information. Mortality, length of stay, unplanned return to theatre and so on, clinical auditing of complications, clinical standardisation via protocols, and adherence to the process points of those protocols, practice improvement projects, benchmarking, all sorts of things. Now let's just show you one example. Neurosurgery. An audit in neurosurgery a few years ago identified an increased rate of wound infection, particularly during spinal surgery, which is a real problem. The aim was to reduce the rate and what was needed to achieve the aim. So the Clinical Practice Improvement Program or methodology provided the framework. We got the team together, diagnostic phase, pulling together so the first bit was recognising the problem, pulling together information on all contributing factors with brainstorming and prioritisation, commenced implementing changes to practice, including the timing and length of time that prophylactic antibiotics were given, the types of dressings, skin disinfection and how long before from application of skin disinfection to actual incision. And then we continued multiple PDSA cycles, continued to review and audit processes, ensuring adherence to standards. So not only were we measuring outcomes, but we were measuring the process points as well. Reviewing surgical techniques, including wound closure, drain practices, etc. And every incident was reviewed each month as part of clinical audit. And this is just to demonstrate measurement of clinically meaningful information was occurring right throughout this process, from the time of identification of the problem to going through the PDSA cycles and beyond. And this is what happened. So this was started in January 2013 up to September 14. Even though the line jumps over, the graph goes up and down a bit, the trend is very much down. And every now and again we do get outbreaks with a cluster of wound infections in various specialties, and we do similar things. So it gets us to improvement science. Understand the problem, identifying a clear goal, involve the people with the fundamental knowledge, most important, use PDSA cycles as we teach in the CIP program, and measure whatever it is that is clinically meaningful. Process, outcome, and a balance of these things. So just to summarise, Measurement needs to be relevant to the staff influenced by the metrics. So at different levels of the organisation, different information is required. So the thing that is required by frontline workers is a little bit different to the thing that might be, some of the information that might be required by senior management, and indeed upon which senior management are judged. This is our philosophy: should be relevant to the domains of quality, should reflect the missions and goals of the organisation, and as I said, different levels of the organisation need different information, needs understanding at all levels. The rolled up KPIs are important to senior management, but are not particularly interpretable by the frontline staff. And this needs to be something that motivates and drives improvement. So there are many types of data from many sources. We need to measure what is relevant to the purpose. Always convert data to a higher level on the data wisdom hierarchy. It is important to interrogate the information that sits behind the data so that you can understand it, like that example of taking out the elective patients. Flowcharts. Really good to use flowcharts rather than just report numbers. The thing about flowcharts is you can watch progress and it serves as your own benchmark. The thing that is most, we always run into this trouble of comparing apples and oranges, but within our own organisation or our own clinical units, by and large, what we were measuring is relatively consistent, and the flowcharts are an extremely important benchmark. And we often use this repetitive sampling. We may measure a lot of things only once a year for a period of time. We would be absolutely overwhelmed with a data warehouse if we tried to measure everything all the time. And the repetitive sampling has been extremely valuable. So, this saying here, the correct carrying out of routine means the difference between success and failure of our organisation. Anyone know who said that? Hudson Fish, one of the founders of Qantas in 1922. That remains absolutely true. We sort of get a bit hung up at times about trying to innovate and be complex and all that sort of stuff. But doing the routine and getting the routine right for standard work is extremely important, and the way we measure and what we measure contributes to that enormously. All right, thank you. I think that's about the time.
Are there any questions either here or on Slido? No. I was just going to ask you about, right at the beginning you showed the mortality chart and how they use that in the US. And just your general reflection on the way performance is monitored and the relevance of how performance is measured in Australia and how it might be improved. So would those types of...
Yeah, so look, the thing in the United States is it's very expensive to be part of NSQIP. Now, most of the American hospitals have to sign up to it now because if they're not, they fall behind the 8 ball. But a few hospitals in New South Wales have signed up to it. It requires full-time data managers, data collectors, and you end up, sometime later getting these printouts. But it's really then what you do with it. And I think that so I was asked whether we would be interested in participating in NSQIP, and I said no, because I think that we would be able to spend the money differently inside the organisation to interrogate the things that we wish to interrogate. I think we have very robust systems to identify problems, and we have a very robust methodology now to solve problems and sustain gains. So I'm not too concerned about not getting risk-adjusted data on mortality, for example. That is an extremely expensive thing to obtain. I think providing you've got the systems inside your organisation, that's the important thing.
Just a quick comment. So what are your thoughts on Health Roundtable and the data that they provide and how useful that is to inform?
So some of the data in Health Roundtable, I did have some Health Roundtable examples, but I took them out because of time. But there are things in Health Roundtable that don't depend on coding, and there are significant parts that do. The important thing is that you just don't accept it at face value. And we had a fantastic example with tonsillectomy. We found that at one stage, our length of stay after tonsillectomy was more or less off the map. And so we then went behind and looked to see what was happening. And in fact, it's the same as the lap chole thing. If someone's admitted with an abscess in the tonsil, a quinsy, and they come in, have drainage and spend time in hospital, it reverts to tonsillectomy DRG. And so, they might stay in hospital for a week as opposed to be just day stay or one night for tonsillectomy. So it was when we went and we had to go behind and discover that before we thought, okay, it's fine, there's no systematic problem. So the important message is you can't just accept it at face value. You have to go back and dig and see what sits behind it before you can draw conclusions, and that's the important bit. It's turning the data into the information, knowledge, wisdom, it's intelligence, wisdom.
Great.
Andrew.
So Rob, can you give us some ideas about variability? Okay, so sometimes you look at a process and we might think that having less variability would be a good part of the process. Standardisation might be one of the comments that you might make on that. And sometimes we can measure variability more easily as a distant measure to an outcome that might be a low frequency or whatever. Do you think variability, we should look at that more often?
Just want to repeat.
Sorry?
Just summarise the question.
The question was around variability and whether we should measure variability more often. The straightforward answer is yes, but it's important that there is an agreed standard. And too often we measure things without necessarily knowing what the agreed standard is. And that cardiology example that I didn't have time to go into was a really good one, because what they demonstrated was a significant variation in outcome according to the consultants that cardiology patients were admitted under, whether they had arrhythmias, heart failure or acute coronary syndrome, and the specialty of the cardiologist. So they were able to demonstrate differences. So sitting behind that, there was obviously variability in practice between the cardiologists. And so I think the important thing, now the solution was to stream the patients according to the specialty, but the other solution would have been to identify what was happening with the various subspecialties, what the variability in practice was, and then design protocols to overcome that, and then measure against that standard. So once you get the agreed standard of what good care looks like, then you can measure it against that. But yes, variability measurement is important, but the standard needs to be agreed.
One more question on the slide. Here's the mic for you.
Okay. How would you recommend we distinguish between an outcome or an output? Or is the language subjective?
I can honestly say I've never been asked that question before. Well, an output is really work done. For example, how many CT scans can you do in one day? That's an output. It's not an outcome. An outcome is what happens when the CT scan is reported, acted upon, and whatever. So I think they're two completely different things.
All right, thanks, Rob.